Okay, so a warm welcome to everybody to the Public Board of Bristol NHS Group. A particular warm welcome to colleagues that have chosen to join us today. So we have some members of the public, we have a member of our our community participation group, we have some clinicians and others who will be contributing during the meeting as well, and particularly a warm welcome to Idara, who's here to share her experience of sickle cell with her daughter's experience of that, and Hayley, the support worker, who's been working with her through that, and Mushtaq, I know you're going to do some introductions in a moment. Also a very warm welcome to our newest non-executive director, Poku Say, who, this is your first board, isn't it? It is. Yeah, so welcome. And also on day 2, a warm welcome to Lavinia Rousell, who is our new Director of Governance for the group.
Morning.
So in at the deep end, Lavinia. Yep. Day 2 board. Great. Okay, we don't have any apologies today, so we are a full house. Okay, are there any declarations of interest that anybody needs to highlight in relation to today's agenda? No. In which case, Mushtaq, over to you and Idara, and a very warm welcome to Dr. Sana and to Rachel as well from Haematology and Children's Hospital. So let's hear your story.
Thank you. Good morning. My name is Mushtaq Hussain and I'm the Community Involvement and Partnership Lead in the Experience of Care and Inclusion team. And it's an honour to introduce Idara and Joanna's story, a powerful story of tenacity, resilience and remarkable strength that Idara and family have shown. Their lived experience offers a vital insight into how our care system supports and works with families with lived conditions, long-term conditions, and how the care system can better support children with long-term conditions. Their story reflects the realities of lots of families that face challenges with sickle cell disease, while also reminding us of the power of trust, partnership and collaboration, and mutual respect between both families, their healthcare system and teams that they work with. It embodies core principles of alliance and valuing patient and public involvement, and shaping services through genuine collaboration and partnership and co-production. As Bristol NHS Group, we have a new health equity plan. I know that's later on in the agenda, reaffirming our commitment to advancing health equity, ensuring that every child and family, regardless of their background and condition, receives the most compassionate and responsive and equitable care. And Idara and Joanne's journey challenges us to listen better and partner more deeply and act with purpose to create a fairer healthcare system for all. So over to you, Idara.
Thank you, and good morning, everyone. My pleasure to be here. It's a great honour for me. Before I start to read my story, I'm going to read what Joanne wrote for this meeting. That's Joanne over there in her prom dress in July. She's 16 in that picture. This was taken last year. She's doing her A-levels currently on the right side, and that's us as a family. Sharon's my youngest. She's 14, and Joanne is the one with the blue jeans. She's 16, and that's me in the middle. So Joanne says, and I read. My name is Joanne and I'm 16 years old and currently attending sixth form. The recent transition in school environment has meant I've had to rethink the way I go about things. Living with sickle cell anemia means that every day requires a balance between managing pain and maintaining energy, especially at school. Some mornings I wake up with sickling pain, such as muscle pain, so severe that I need strong medication, which can sometimes affect my ability to focus and perform at my best, and at its worst, takes me away from school entirely. This can be extremely frustrating, as it can feel like I'm miles behind my peers over something I cannot control. My stamina is often lower than that of my classmates, and exhaustion can limit how much I'm able to participate in activities throughout the day. Because of this, I've learned to be very self-aware and able to recognize when I've reached my limit and need to rest, even when there's still so much to do. I also try to limit how often I take medication by finding alternative ways to manage pain, such as massages, listening to music, coloring, and other calming distractions that help me stay grounded. Each day teaches me more about what my body needs and how to care for it. I am constantly learning how to make the most of my energy without overexerting myself. So that's Joanne. And my story goes, my name is Idara. I'm a single mom with two beautiful girls, 16 and 14. My 16-year-old, soon to be 17, is Joanne, and she lives with chronic sickle cell disease. I'm glad I don't need to tell anyone in this room what that is for once. I remember last year when Joanne had to go into A&E due to a crisis. The failings were catastrophic, starting from the ambulance services when they came into our home to take her to hospital at about 9 a.m. There was a lack of empathy and no connection between the paramedics and the child who was reeling in pain. They didn't seek to understand what was wrong with her, but rather started making assumptions such as the possibility of her being pregnant or pretending to be in more pain than she actually is because she was presenting with abdominal crises. They certainly did not give her the first aid treatment and the immediate medical care and support she required from them as first-line responders. So Joanne's pain was completely ignored, even to the point of being allowed to come down the stairs herself without any support. I hurried out of my bedroom after getting ready to go with her to the hospital, only to find her struggling on her own to come down the stairs with severe mobility issues and the paramedic waiting at the bottom of the stairs without a care in the world. At that point, I knew I had to ride with my daughter in the ambulance. Excuse me.
It's okay.
As I would normally drive behind them in my own car. Thank you. In the ambulance, the paramedic then gave Joanne a vial of morphine and even made a joke to her colleague to say that she could do with some of that herself. We got to the A&E and they refused to give her a wheelchair or even support her into the hospital. And I've not written this, but the paramedic also made to say that she's going to go into triage anyway. So what's the point in getting her a wheelchair or putting her on the bed that was in the ambulance to get her into the hospital? And this was a child presenting with mobility issues. I was left to carry out overnight hospital bags and my 15-year-old in both arms. While in hospital, Joanne's treatment was further delayed for about 6 to 7 hours because the paramedics had failed to record the morphine dose and the time they administered it. While in A&E, the nurses attached to her were new. I know this because I asked. This is the next one. Okay. They may have been fantastic nurses, but on this occasion, they failed her abysmally because they did not have a clue what to do, even after I told them repeatedly to look into her care plan for clear guidelines on how to support Joanne in circumstances such as this. They were laughing the entire time and downplaying the severity of Joanne's pain, and they did very little to help her, and even the doctor was a bit dismissive. They didn't understand that Joanne's pain was so severe that it could cause organ damage or even if not managed properly. They were just simply neglectful of her, and every time they saw Joanne more as an opportunity to learn something new rather than a patient coming in and needing help, support, and immediate medical attention. So Joanne has an access port, and not every nurse in the hospital knows how to access it. So every time we go into A&E, the nurses who do not know how to access or, the access port see it as a learning opportunity, but the child is in pain and you're saying, can you show us how to do it? And they're poking and prodding. So that happens every time. And so that is what I'm referring to in that statement. Joanne's pain was not stabilized in A&E as a matter of procedure, and we were sent up to the ward with a 10 out of 10 pain score. It took me almost losing my mind at about 10 p.m. and nearly waking up the entire ward for my child to get the help that she needed. She was in pain the entire time, 12 hours. I know this because I counted. I recount this particular experience just to say that the emergency care remains the most traumatic part of our journey. Now, Joanne experiences anxiety whenever she needs A&E services, saying, "Mommy, I don't like it there." There's clearly a lack of empathy and knowledge about ambulance and A&E staff, delay in pain management and repeated questions despite treatment plan being available. These experiences erode her trust and create fear, especially when compared to the safe, familiar environment within the Ocean ward. Sadly, Joanne also feels unsafe to travel alone with the ambulance services or go to A&E due to several contributing factors, which is lack of empathy and knowledge among the ambulance and A&E staff, delays in pain relief, despite treatment plans being available, repeated questioning, which adds stress and undermines confidence in care. I will also recount a time when Joanne was 7. She experienced a severe episode where her lungs collapsed. During an emergency surgery and an exchange transfusion, the clinicians discovered a hole in her heart, leading to cardiology referrals. This was a turning point for me as I noticed a stark difference in the wraparound care, non-medical care and support between cardiology and Ocean ward in the Children's Hospital. While the Ocean ward provided emotional support, practical assistance and reassurance for Joanne, however, the structured, coordinated and wraparound support available in cardiology was noticeably absent. I recognized this gap and I advocated for change, which ultimately led to the creation of a dedicated benign support worker role in the Ocean unit that happened over the pandemic, a development that has transformed our experience in the hospital completely. This role provides Joanne with in-reach care across all clinical areas where her relevant needs are cared for, ensuring continuity of support as the role follows Joanne throughout her care journey. I was part of the parent team who interviewed Hayley Wiles. Hayley sat next to me, the family link support person for Ocean ward, and I can honestly say that I don't know how we were able to cope with the past years without her. She's phenomenal at what she does and how she supports families. As a result of Hayley's role, families like mine can now access wraparound care as required. We can also gain access to platforms where our voices can make an impact, like this one. Despite these improvements, I still face significant challenges in the community. I tried to create parent support groups but encountered cultural stigma, which made it difficult to connect families, but I didn't relent. I printed leaflets and shared my contact details, but found that one-to-one support was more effective throughout, though time-consuming. So I would tell Hayley to pass my contact on to any parent who is new joining the team, if they needed support, if they needed anybody to just speak to. I was available. Education is another major hurdle that Joanne has had to cross. She and I. Hospital appointments and sick days often meant a lot of absences. Schools lacked understanding of sickle cell disease and its complex needs, making transition stressful and isolating for Joanne, often being called lazy or not wanting to participate in school and class activities and not seeking to understand exactly what the problem is. Hayley's role now helps with school letters, relevant information, and emotional and practical support. But I've had to navigate much of this alone for years in the past. I should also emphasize the need for cultural competence and sickle cell specific training for emergency staff to address these systemic gaps. I have also raised concerns about the lack of development in sickle cell treatments and the need for equitable access to emerging options like gene therapy. Reflecting on systemic inequalities, racial bias in emergency care and navigating these challenges as a single parent can be very mentally and emotionally draining. Being a mom to Joanne and Sharon means I've had to take certain decisions on the spot and often alone. I have also had to work full-time jobs and manage a business to help support my family. Oftentimes, I find myself on autopilot and forget to even take time to breathe. Even though it can feel often overwhelming, I'm truly grateful for the team at Ocean and how well they've supported us throughout these years. It's a consistency, continuity, and the fact that we do not have to explain ourselves every time we go there that makes the journey more bearable. Joanne's treatment journey has included frequent transfusions and later replaced with exchanges to manage iron overload. Throughout our medical journey, Joanne has been supported by an amazing team of experts in Oceans. At the top of that list is Dr. Michelle Cummins. She is pivotal to Joanne's medical well-being, and her genuine care and concern for Joanne meant I could trust her sound judgment whenever we needed to make decisions or change of plans as it concerns Joanne's care. Michelle was the first face we ever saw at Ocean Daybeds, at On-Call Daybeds, now called Oceans, and Joanne was about a month old when we went into Oceans. She was diagnosed with sickle cell at 5 days old when she had the heel prick. And from first week, we were on the list, and we knew that the journey was going to be a tough one. Her consistent care for Joanne means she has seen her her best and at her worst. Also, Joanne has her dedicated hematology nurses. Even though these faces have changed a few times these past years, there is a common thread of consistent duty of care that runs across all the nurses who care for her. In Oceans, I can leave Joanne there knowing she is well looked after while having her treatment. If I needed to go out to work or pick up Sharon from school, help is often a phone call away on the ward, no matter what it's about. We are considering the gene therapy treatment. It is currently available as a treatment for sickle cell disease, and are starting therapy to help with the mental health support required to prepare for it in a few years' time. Despite everything, Joanne remains resilient, happy and emotionally balanced teenager, and dreams of becoming a clinical psychologist specializing in pain management, a world all too familiar to her. She is currently one of the young board members of the Make-A-Wish Charity Foundation, which provides moments of joy amidst hardship for sick children. Joanne is also an avid artist, a skill she developed to help her manage painful episodes. 3 years ago, she designed stickers for the ward, which was sponsored by the Wallace and Gromit Foundation. She felt the ones that were going around were too boring, and these are the stickers that she designed herself. She felt the ones that were going around were too boring, and so she decided to do something about it. They have since been made their way around all the wards within the trust. Joanne will be 17 in a few weeks. We and the team at Ocean have spent the past years preparing for her transition from pediatrics to adults. If I have to be honest, it is not something I'm ready for, as I will no longer be able to have a say or manage the decisions about her medical care and needs as I have done in these past 16 years. I had to seek therapy to help me deal with this, and I think it should be a recommendation for parents of children living with chronic and complex illnesses when they transition. It wasn't something that was available to me. No one told me that is something that I needed to do. I mean, I remember Haley telling me about the transition. Haley started working with us from when Joanne was 15, just to let us know gently that Joanne will be transitioning to adults. I think the first day I ever heard that, my heart sank, and I thought, I'm not going to be able to make any decisions about her health anymore. She's only 15. She will be 16 and 17. And I think even till when she's 21, she's still going to need me. But unfortunately, I have to be a fly on the wall when she turns 17 and goes into adults. And I think parents need to be prepared for that, because it's not something you ever think about, especially when you've been in the system from day one. That's my story. Thank you, everyone.
So Idara, thank you for sharing that. We can all see what it's cost you to bring that story to us, so really, really appreciate it. And you're awesome. I mean, to have done what you've done through 16, 17 years to support your beautiful daughter is really, really impressive. And she is amazing. Despite all of these challenges with her health, you've told us, you know, just how talented and giving she is. And thank you for, through your story and your work, making a difference, because Hayley wouldn't be here without you, for example. So thank you so much. But I'm going to open this up to the wider board for any thoughts, reflections, questions. Maria?
Thank you. Actually, a question for Steve around training. I think the experience of sickle cell patients in ED is generally pretty poor, having to fight to be believed about the level of pain, etc. We talk about providing trauma-informed care, and I'm just wondering how that lens would be applied to sickle cell patients. And your point, Idara, about racial bias, you know, subconsciously, how that plays in about that lack of recognition for levels of pain, despite what people are saying.
I agree, Maria, and I think there's much for us to take from experience. In fact, Rachel's here, Director of Nursing for the Children's Hospital, and I just wonder, in terms of supporting our colleagues, particularly in ED, around training, just to be clear about what we do offer. But I think there's much more to be done, clearly, in terms of recognising pain, but also some of the racial biases that we've seen and experienced.
Yeah, I would agree. I mean, I spoke to Hayley before, and Hayley ensures all the correct care plans are up to date for all of the patients on Evolve, which can be accessed. But I've also linked in with the lead for CED, who's one of our consultants, Bianca Suella. And it's important that we obviously learn completely from this feedback. And she's talking about continual professional development sessions from your team into the CED team, and maybe having a CED sickle cell champion who can work with Hayley and yourself potentially about looking to ensure that the right information, right education is at the right level for patients. And it's particularly, all hours, because we're 24/7 service, but I understand a lot of presentations are out of hours, can be around the school day. And doing mini sims and things like that within ED. And I know I picked up from your story, and I know we've chatted several times already about a key focus is the ambulance service as well. And I think I've got to get my thinking head on about how we involve our ambulance colleagues, because that's been a consistently not positive experience for you. So I'm taking away a lot of learning for my own CED department, but I think it's a wider emergency care pathway that we need to look at. I don't know, Hayley, whether you think of anything else that I've missed out.
I think we, as our team, do training with ED and SIMS, but maybe I think we need to do it more consistently. We need to check what staff have had that training and who needs updating, because there can be quite a high turnover of staff. They may not be on shift that day. So I think it needs to be targeting the right people that need it at that time.
And I think, it was also in my learning about this patient's story and my learning in general, I was talking to John Moppet, who's one of our consultants, and Michelle from the Children's Hospital, and where we've normally previously had 4 to 5 patients diagnosed a year, we're now seeing 44 patients diagnosed for the Southwest in the last 3 years. And I think it's key to us to remember, I know we all know that we are the Southwest service in adults and paediatrics. So it's how we help our colleagues in the Southwest to support these patients when 2/3 are in our region, not Bristol.
I mean, I guess the other thing, Chair, if I may, is just how we might get some of that learning and education in the undergraduate programme, Mark, particularly for, in fact, all undergraduate health professionals. In fact, and I think there's something about, there is an informality and flippancy around pain generally. I can't help but think that might be higher, particularly around young people. So, I think there's much more for us to learn, but getting in the undergraduate programme, I think, would be incredibly helpful with Rachel's key points. So look forward to working together on it.
Thank you. Now, quite a few hands going up, so if we can just focus. So, Mark?
Yeah, absolutely succinct. Dira, thank you so much, first of all. I'm very grateful for the story that you shared today with us. I think having the photographs has really, really helped to picture and, see, your family. Thank you for the bravery of sharing your story. My point was going to be around the education and training. I did do a little bit of homework before today just to check to see where I work at the University of West of England, Bristol, where lots of nurses are trained across all fields. And I've done a bit of a sense check. I haven't got an answer back yet, but I have asked questions. But where does pain management, sickle cell anemia, and wider conditions that may not be that common, where are they taught and at what level? I also think there's something about the postgraduates when they are trained, the nurses, something about the reflections on back to the points made, some kind of sharing, safe spaces for that, for when things didn't go well, what happened, what was informed, where do we use this to go forward as well. I think with the appointment of Hayley in terms of your role as well, really, really important. So I will take that back as a kind of as a viewpoint. My only other question was going to be, I could see how upset you were about that transition from child to adult. And I really wonder where, as a hospital group, we really focus in on support for mums, dads, carers who are transitioning themselves for their loved ones as they go. I could really see how that meant, a lot to you. So I'll throw that out there as a kind of question, but, an inspirational story. Thank you.
I think Dr. Sanna might want to come.
I'm one of the hematology consultants and the lead of our hemoglobinopathy coordinating centre in southwest England. I see a lot of sickle patients after they've transitioned in the adult services. What is important to know, there is already in place the Ready, Steady, Go pathway where, as Hayley already kind of mentioned, transition due and parents and the patient up to our adult services. It's not that in adult services you can't attend clinic. We're very welcome for you to attend whatever you want. You've also got say in what happens in the care. What is important that we train our staff into the transition pathway. There are psychology services available, and also they are sometimes available for parents in specific cases. But I would definitely agree there is more attention needed there, because it's just as traumatic for the parents, just the support system of the patient, as for the patient itself. I'm very happy to meet you there when you go. Thank you.
We'll be seeing you in a couple of weeks.
That's a good offer, thank you. Martin, I think you wanted to come in then.
Thank you very much for the story. It's comments probably for the trust, two quick ones. First one is, when we responded to the first question, and we're very quick on these sorts of incidents to rush to sort of training, the computer, what can we see, the notes, and I think we have to be careful not to lose the sort of personal touch bit. And, when we're in this room, we hear stories like this, you get to really live that lived experience and understand how people really are. And I think sometimes we lose that in the sort of hustle and bustle of emergency care and things. So my question is, how do we make sure that we give people that experience, knowledge, understanding, constantly updated, really, to stop people reverting back into that, everybody's a number and everybody's a note, rather than they're real people with personalised care issues. My second one, slightly building on that, I know we've got the equity piece later, but it's still, every time we have an issue like this, and unfortunately we do have them, we keep eroding sort of trust and confidence in communities in this organisation, all the big trusts that we run, and I still haven't quite got to grips with how we rebuild that. I know we've got to do it ground up, start small, get other people in health communities to help us, but it feels like, we're 2 steps back, 1 step forward if we're not careful, and I still don't quite get from the health equity feedback. I know we can talk about it later, how we really try and make those inroads to try and build that confidence so people don't feel, this organisation doesn't work for me, why I'm ever going to go there, or it's treated badly. We've got to try and push back against that and rebuild that trust and really make effort to do that, I think.
That's a big conversation. I don't know, we'll have to consider where and how we have that, but it is really important, Marty. Thank you. Sue?
Thank you. Really, it's so important you come and share this. And there were some nuggets of really fantastic care. I think we always zoom in on where it's not going so brilliantly. And there's plenty of evidence. And I want to follow up on what Martin was saying. And I've got a couple of questions, because you and Joanne are the experts in all of this. If you think you've lived this experience for 17 years and your treatment and management plan must be full of all the information nearly that anybody would ever need. And I suppose my challenge back was, why, as a trust and many trusts across the country, don't use the treatment and management plans and that individual personalised care needs when people come in to the trust. So my question first is, when somebody comes into A&E, are patients like Joanne flagged on the system so that we will know, because in other trusts they do this, they flag them, they will know there's a treatment and management plan, and the staff, would they automatically go to look at that so that they don't go through this? I'm an ex-A&E nurse, asking the same questions. It must drive you mad. It's saying people when all the information is there was my first question, flagging on the A&E systems. And my second question really is to Neil about digitisation of these management plans. How soon are we talking about, so that you don't have to cast around bits of paper, so that they can type in, and this personalised, digitised treatment plan, what are we talking about? 2 years, 5 years? So this is my challenge of what's happening in A&E and digitised plans, really.
Okay, do you want to start with A&E? I could see lots of avid nods from clinicians in the room. So
all of treatment plan, escalation plan are all digitalised, all on Evolve, and all very active with alerts on the system. So there is an alert for any child that needs an alert for any condition, and that's the first thing. So if I look at an ED dashboard today, I could look down and see who has an alert, and ED know to go into the alert, and it's all IT on that.
I guess the challenge is, though, you can still go into the alert.
Yeah.
If you don't quite understand what it's telling you, what you
Yes.
then need to do, which I think is what's been described. That's the end we need to.
Yeah, and we need to do the interface between the sim training and
Yeah.
and the education for the peninsula as well.
Would that be the same in any department? So
Yeah.
any department Joe goes to in cardiology.
Brilliant.
Excellent.
Neil, anything to add from a digital perspective?
So I agree. We do have pockets of quite sophisticated digitisation, but we don't have universal access to those systems. So if a patient was to go to Southmead ED, that information wouldn't be readily available. So we have work to do to use our group position to make sure that we're resolving those challenges. Because where we've had pockets of innovation, we're now together and we haven't had the opportunity to spread those across the wider areas.
Thank you, Neil. So work to do still. Tim, I think you also wanted to come in, so we'll give you the last word.
Okay, thanks a lot. So it's an absolutely amazing story. Sorry, I stole a sticker. I don't know what I was supposed to.
Are we allowed to take one?
I assumed we were.
All right. Send them round again.
Just for colleagues in the room to point out. So I think you've highlighted a number of points there. I mean, the expert high-end care. I think we get very, very, very well. We do very well. The wraparound and the lived experience we don't appreciate very well. Just to flag people, if they wanted to do some homework, Bristol Health Partners produced a series of videos last year, I think, Maria, wasn't it? Which was supported by Primrose Glanville. They're very easily watched on YouTube. The first video talks exactly about the lived experience and what it's really like to live with sickle cell disease and how it's often very hidden from the rest of society and the impact. And the second video does touch upon, as you mentioned, the gene therapies, which are an enormous potential step forward. But obviously there's uncertainty and confusion around the gene therapy process. But the second video does go into that. So it's just to give you some homework.
So good videos. Maybe we could share these if people are
share the
interested in
links.
following that up. That would be good. And Primrose, who Tim referred to, is also, along with Peter, who's over at the back there, a member of our community participation group. So it's great to have her all foot and support as well. Maria, very last thing.
A follow-up question, Zara. Just so you've talked about your hospital and ambulance experience. Have you had support from primary care or community care in your journey? Obviously, when there are pain crises, you would obviously need to come to a hospital. But in terms of ongoing management support to you and your family, has there been any other part of the health service that has been useful and that you can rely on?
Do you want the honest answer?
Yeah, we do. Yeah.
No.
Okay.
No is the answer to that question, and for two reasons. I always have to repeat myself every time. Joanne goes into hospital looking like that. She, in that photograph, she was having a crisis. She was in pain, but she had to go for her prom. You wouldn't tell from looking at her in that picture. In the other one, we were on holiday in Lisbon, and that was in October. She was in crisis. She just got out of bed. We had to go out, and I had to literally. So in those two pictures, quite important. The reason why I picked them was because in those two pictures, she was having a crisis, but you couldn't tell from looking at her. So I take her into the GPs looking like that and telling them she needs urgent care. They're gonna laugh me in the face. I've had that so many times. When Joanne was about 4 years old, we used to have the prophylactic penicillin, and that was constituted at the GPs. They would give me a bottle that lasts a week, and they would insist on constituting it, and then I'll take it home. Then I had Sharon, who was a baby at the time, and I said to them, I can't keep doing this. I can't keep coming back. Do you mind giving me 4 lots of it for a whole month? I will constitute it at home. Give me the syringes and tell me what to do. And the receptionist laughed me in the face. And then the next day I went to pick it up. She said she had been flagged up to social services for penicillin abuse. And I burst out crying because the kid was unwell and I needed to have the prophylactic. And then I picked up the phone and I rang Oceans Oncology at the time. And, they said come back the next day. and the receptionist gave me obviously what I asked for. I mean, obviously they've had a bit of education around there, but it's experiences like that that have kept me away from going to, to the GP. I don't go.
Yeah.
So yeah, that's a simple answer to that question.
Understood. It takes us back to the trust question, doesn't it? Yeah. Last word from you.
No, I just wanted to say, and I know Idara mentioned stigma, that also the point that was made earlier around the trust eroding in communities and the work that needs to happen. There are services, but because of stigma, not everybody likes to take up those services. So I think it highlights the need for real important work to tackle those disparities with communities individually and families.
Yeah.
Whoa, so thank you again. I mean, what you've said has been hugely impactful, and I think we have identified some practical actions that we can take forward from here, building on work that's already obviously going on that we've heard about today, and we need to talk to some of our partners and colleagues as well about their part in this. I'd just like to finish, Idara, by saying congratulations to you and to Idara for doing so well, to Joanne, and wish her well for her A-levels and her ambitions for the future. So go well. Thank you. Thank you very much. Can we have a look, please, colleagues, at the minutes from our last meeting in public on the 11th of November? Are there any amendments? I have one tiny typo that I didn't notice before.
Steve's just made mention about his title isn't right.
Oh, we thought we had that right last time. Have we got it wrong again? Yeah, we got him as innovation or whatever rather than improvement again, have we?
But you'll need to check with him.
Okay. All right. Okay, any other amendments? Just a small thing in my group chair's report, but I raise it particularly because it relates to what we've just heard. The sixth bullet point, I think, it talks about the visit that Glyn and I did. It's actually to ARFI Health, and part of the learning around that was about accessibility of trust and of services in building trust. So just to correct that in the minutes if we could. Any other amendments? Okay, we'll take them with those small points as a true record. And in terms of matters arising, the only action point is improving local engagement, verbal update. And I'm assuming I'm looking to you, Elliot, for this. Excellent, thank you.
So since the last meeting, it's been very clear that both trusts have always held local engagement with their communities to be really, really important. The trick now is to move it into the group space. So I'm really happy to say that within the proposal for the new communications team, there will be an engagement team. The idea is not to centralise everything, but to create a single point of coordination. And we've made some really solid progress since the last meeting. So I'm happy to say that met with John Lee from Steve Ham's team to talk, how do we pull together health, wellbeing and locality partnerships? How do we build on the great work that the estates team are doing with around the capital programme? All of this activity is happening now, and then you've got at MBT the commitment to our community. A lot of it is happening in isolation. We're looking to bring that together so we can share learning, share information. It's not about stopping people doing the great work they're doing. It's about just so we have clear oversight and we can share it as a group. We've also linked in with the Trust Secretariat, who have a great series of public meetings as another way of engaging directly with the local community. All these are fantastic avenues which we don't need to build. They already exist. We just need to start coordinating and bringing things together. And then building that on top, we've got our fantastic partners out in the community who have fantastic roots themselves. So if you think of Bristol Rovers or even Gloucestershire Cricket Club and some of the schools in the local area, we now have direct relationships with an awful lot of them since the last board meeting, which we're already starting to use to help build those relationships directly in an organic way, rather than it being we set something up and you must come to us. So we're looking to go out to them. Lots more to do, but I think we've made some really solid progress, and we will absolutely continue to make this a priority. I'd like to thank the member of the public for the question, because it's certainly accelerated what we were planning to do, and it's been really helpful for that.
Thank you. Anything people want to pursue from that at this point? it's a big conversation for another day, I think. But, and then the group board assurance framework does now include a specific item on no criteria to reside, which is what we had asked for. So that item's closed. Are there any other matters rising that people would like to follow through from the minutes? No? Okay, in which case we'll move on to the chair's report, and you'll see from that I've been involved in the normal sort of range of internal meetings and visits to various services. I would just highlight the visit from the AWP chair. So this is our counterpart Mental Health Trust. So he and I visited actually Ocean Ward that we heard a lot about earlier, and the children's ED, as well as adult ED and psychiatric liaison services. And it is clear that there is a huge amount that we need to develop further around partnership and joined up working, and I'm sure that those things are being pursued. I was also really delighted to join the Group Women's Network and to be able to share some time with them. It was an hour of real openness, honesty, mutual support, but also a sense of actually there are still frustrations and inequalities that need to be addressed. So onwards, sisters, we will keep on with that one. And then partner-wise, again, I've been really quite busy, particularly working with Elliot's team just lately to make a plan for stakeholder engagement, especially in the run-up to the merger. And so you'll hear more detail about that in my next report, because we're kind of midstream in it all. But Maria and I tomorrow are going, for example, to speak to the One City Partners breakfast meeting. And there are lots of other places that we've been connecting with. MPs, we had Karen Smith with us last Friday. But also I'm connecting with lots of other elected members, third sector organisations and so on. It's great to have Peter from the Community Participation Group. That is continuing to evolve and develop. Steve, it's a pleasure to be part of, isn't it? And it is now at a point where it is starting, and Paula will be able to come on this later perhaps, and Tim. It is starting to develop a framework to guide the way that we work with the clinical strategy when there are particular levels of change or things that people using the services would notice, such that we need to co-produce the changes and new approaches with them. And thank you, Matthew, also, Ushtak's gone, but for your support in that work. One of the other things I thoroughly enjoyed, and Sarah was there, was chairing the NHS Race Observatory Regional Roadshow, which Gifty also spoke at from MBT, but very much highlighting, yes, some great stuff and some good practice going on about the inequities that racialised minorities experience within our workforce in the NHS, but also loads still to do. So the observatory is doing a very particular piece of work, gathering both quantitative and qualitative data about the state of play here and now, but also marshalling best practice that we can all learn from, and that will be coming forward in a report later in the year. So it was great to be part of that. I suppose one other major connection that we've made over the last month or so has been the visit from the Mayor of Wecker. She came, actually it was mostly to MBT, but she was interested because of the growth plan that Wecker has and its emphasis on innovation. She wanted to see some of the innovation work that we were doing. So some of you will know this very well, but particularly looking at genomics and robotics. So yeah, we'll be following through on how we develop that further, Tim, with your innovation work as well, and obviously with the universities and local business and commerce to roll some of that work out further. Anything from the vice chairs, whose report is there as well, for any comment or question?
Just a comment, really. Obviously, a very busy time for you, Ingrid, and for Sarah as well. Very, very flat out. I think the official launch of the new One City plan, which is due for the 27th, I believe, of this month, that I think brings real opportunity for the hospital group in terms of the theme on the day, which is about young people, I understand, children and young people, but also the wider kind of focus around health and well-being and communities. So it's just about how we keep on top of that, I think, as a board, as a non-exec kind of team as well, because I think that is potentially going to move quite fast once it gets going and once it's launched. So it's just thinking with a university hat on, but also with my NED hat on, in terms of how we are positioning for that as well. Maybe something just to think about. But yeah.
Great, thank you. We'll look for that. I'm not sure it's in the diary for any of us, but we'll check it out.
27th of, someone should have had an invite somewhere.
Right.
I'm checking.
We'll certainly check.
Yeah.
Okay, thanks, Elliot.
It's at We the Curious.
Yes.
Invite only though.
Okay, all right, we'll make sure we've got it on the radar. Thanks, Mark. Okay, any other points? The report is for information, but happy to put anything up. Okay, over to you then, Maria.
Thank you. Report mainly for information. A few major strategic documents have come out, particularly the Strategic Commissioning Framework, which we are using to support our medium-term planning framework. We're in the middle of medium-term planning at the moment, with submissions in January and a final sign-off mid-February, with an expectation of submitting a compliant plan, both in finance and performance standard terms. As we know, there are local challenges and expectations about how we deliver that plan, which requires system partners to work in a way that supports flow through our system, and we've been very challenged on that in recent weeks going into critical incident. We'll hear a little bit more about that as we go into our performance report. But despite that, we have retained our position, in fact improved in NBT's case a little bit in the Q2 National Oversight Framework segmentation. So we continue to be in League Table 1 and 2, which is a fantastic tribute to staff across both trusts. Because of that, the new oversight framework from the Southwest region, because the region now retains or has as main responsibility for performance management, a much more proportionate oversight. So if you're in League Table 1, you just have a once a year oversight meeting, League Table 2 twice a year, which is, I think, music to our ears, actually, that we're not being dragged in when so much of it is now very reliant on data that is freely available. So that's positive. Industrial action was well coped with. It continues. We are working very well with our resident doctor through the Resident Doctor Forum. We have a 10-point plan, which we are supplementing and working with our resident doctor representatives. Obviously, pay negotiations remain in the realm of government negotiation, but we are certainly doing what we can in the non-pay incentives, with extra training opportunities, roster issues being resolved, and some of the prompt payment issues that our doctors were experiencing also being resolved. But that is a work in progress. And again, we managed to maintain our 95% elective trajectory through that period, which is absolutely fantastic. So again, huge thanks to all staff. A number of successes and accreditations, etc., noted in my report, which I won't go through. Also, in terms of addressing equity, I know we have health equity discussion later, but in the latter part of the year we marked both Black History Month, Disability History Month, and also looked at the recently published update on actions around sexual misconduct prevention. And again, the new expectations that are being referred to, I'm pleased to say, are already very much being thought of or implemented already within both trusts. Just lastly, on the Genomics Healthcare Summit, a very big summit with Dame Sue Hill. I chaired one of the sessions. Just really struck with the opportunities for genomics in population health, pharmacogenomics, personalised care, and an expectation that by 2035, pretty much all of our healthcare interventions will have some aspect of clinical genetics, genomics in that. Really been able to target and provide excellent care right from birth, or pre-birth actually in some cases, in rare and inherited diseases. And again, just we are a provider for the whole of the Southwest, having run the contract. Also very keen that we'll be doing some more whole genome sequencing work as a centre of excellence here too. I would like to note that Tim will be taking up, or has taken up, the new chair of Bristol Health Partners. I stepped down and Tim has been elected as the new chair with a 3-year term to go. Also delighted to welcome Lavinia, as Ingrid alluded to. Very welcome, day 2. So lots to do as we work together on a number of fronts around our merger process, becoming a group, and then making sure that we really are able to pull out our 4P benefits as quickly as possible. Also, we've had a number of New Year's honours across the Trust. Dr. Fiona Donald, Anne Remmers, our former NBT midwife and Director of Midwifery, and also Jane Hadfield, a former Head of Learning and Development at NBT. And then just to note that Professor Jonathan Benja has been appointed the CEO of NICE, which is fantastic. A huge honour for he having been at UHBW in a consultant in ED for some time. So we look forward to continue to work with Jonathan in a slightly different way going forward. I think everything else is self-explanatory, but happy to take questions.
Thank you, Maria. Anything people would like to follow up from that report? Okay. I would just like to take this moment to say, well, to recognise the enormous pressures, actually, that both trusts have been experiencing with the critical incident going on for days. Actually, so thank you to the teams, thank you to the execs. Must have been, well, continues to be incredibly tough. So thank you for everything you've done to hold things together, and congratulations to all of you for maintaining position with the oversight framework. It really matters. It isn't just a gold badge, it's a gateway into being able to do things and have freedoms that we otherwise wouldn't have. So it really counts. And also keeping the levels of delivery up during industrial action, all of that, it adds up to huge pressure, and thank you for dealing with it so ably. And also, it's been great to see in your report, Maria, in amongst all of that, real examples of excellence, of innovation. Great to have recognition of some of our colleagues in the way that you've described as well. So I think we're really encouraging. Thank you very much. Okay. Well, if there are no other points on that report, let us move onwards to the group benefits realisation report. And I'm going to hand over, I think, to Paula, but I believe Tim and Neil will also be helping to present elements of the report. So over to you.
Thanks, Chair. So just a short reminder, back in April last year, we set out a very ambitious and exciting vision for ourselves as Bristol NHS Group to deliver seamless, high quality, equitable and sustainable care. And along with that, we set out a very clear number of benefits that we expected to achieve across our 4 Ps, as we call them, our patients, our people, the populations we serve, and the public purse. And this report is our second report, which is where we hold ourselves and start to hold ourselves to account to really try to evidence the impact we're making as a group above and beyond the kind of business as usual performance reporting that the board is very familiar with. And I think it is important to remember, in some ways we are being innovative here. We're trying to break a bit of new ground because nationally we haven't seen successful ways of demonstrating the impact of operating in collaborative model like a group makes. And so we are trying to push ourselves to really be able to evidence that. And we do want to adopt continuous improvement approaches to that. we've got to test it, we've got to learn. So interested to hear the board reflections today. This is something we will keep building on, and we will keep adapting. So the report today, I'm not going to try to summarise it. There's a lot in here. So it's got 3 key goals, if you like. The first is to set out where we're at in defining the non-financial measures, both qualitative and quantitative, that we are proposing to track across our delivery work streams. We have started to track some of those. We've got trajectories for ambitions, and we need to continue to build those trajectories across all of our benefit realisation plans, with the aim of starting to report on the performance against those from our next report in May. The report then also sets out the financial benefits that we're tracking, again, resulting purely, if you like, from our way of operating as a group that Neil will cover. And the report also wraps in, if you like, the joint clinical strategy as one of the key areas of benefit delivery that we want to achieve. It gives a general update, as well as an oversight of some of the specific benefit measures across the 4 clinical services, our group clinical services, where we've got single leadership in place here and now. And I think you can see there that is about investing in incremental gains approach to improvement. So it is about building service on service, building operational excellence, efficiency, transformation, and in so doing aggregate across all of our duplicated services so we make large scale impact. There are some helpful case studies there, which I think is really important. We recognise not just in our clinical services, but the transformation we're making in our corporate services, in digital and people, in our recruitment and international health opportunities. And we have made very significant progress in our corporate services transformation programme, where we're really redesigning and modernising our corporate services. So we've got that simpler platform for our clinical teams to engage with, to then lever out the clinical benefits. And I just wanted to draw attention then to the reporting arrangements. So in terms of how we've done it a bit of a test and learn in the People Committee in November, bringing a deeper dive update on the people benefits into the committee to discuss, and then reflecting sort of at a higher level into the board. I don't think we've got this right yet. I think we need a much tighter dashboard to report into the board and use the committees to have the deeper dive conversations. It may also be that something we want to think about is something like a biannual report approach maybe in the future, where it's a much more, frankly, publicly engaging version, if you like, of how we are doing as a group. So lots of thoughts, but a lot to cover. So keen to hear the comments.
All right, thank you. I wonder whether it would be helpful to take the report in chunks, because it is quite lengthy. So if we can focus first of all on what you've covered, Paula, so around benefits delivery reporting arrangements, the kind of overview that we expect to see about performance, that kind of stuff, and also comments on the evaluation that's progressing with the Health Innovation Network. So if we can maybe have any thoughts, comments on that bit, and then Neil, if we could turn to you for the update on the financial benefits, and Tim on the JCS. Can we do it that way? Might help to just focus us, otherwise we're going to be all over the shop, I think. Right, Martin, Sean and Linda.
Me first. Thanks, Ingrid, and thanks, Paul. I mean, just reflecting back on when Western came into UHB, it took probably quite a long time, further than we expected, I think, to do the clinical integration. And we had a Gantt chart that showed us, when we expected to do things and when they actually came. It's difficult to tell from reading the report whether we feel we're sort of on track, slightly behind track, or ahead of track, I suppose, in terms of where we're getting that integration happening. Can you give us a sense? Do you think we're on target where we expected to be, or do we need to sort of help people along a bit quicker?
Well, if you're talking specifically about clinical integration, I'll make a comment, and Tim, if you want to come in, so there is a Gantt chart, there is a kind of a trajectory for the 40 duplicated services, Martin, as to where we want to be. I think it has taken us a bit of time to get to that point. I think the learning that we have taken from cardiology is really allowing the acceleration to happen, and the cardiology team, the single leadership team, are being really generous in sharing their reflections in with other clinical services about the mistakes to avoid, and how to get some impact kind of early. So so we've got 4 group clinical services now, but we've got a clear trajectory. So if it's useful, we can obviously build that into future reports.
Probably would be. Tim, had any comment? No. Thank you.
Thanks, Chair. Thanks for that, Paula. I just wanted to pick up on in this section really on your comment about the continuous improvement side of it, and I think that's really clear when you read the update on the joint clinical strategy, which is later on, and so I think that's something that it does clearly permeate, and perhaps we've undersold it a little bit, because I do think we're clearly doing that, and it's bringing the benefits, and we're going to, in some cases quicker, in some cases slower, but we're learning. So I think we just need to make sure we've got that holistic approach to it, that we're going to be ahead on some, behind on others, nowhere we're behind and nowhere we can catch up. But I think it's it clearly comes together, albeit it's maybe not that explicit, but it clearly does if you read the two. Thank you.
And Linda?
Yes, so I just wanted to say that it was great to have that deep dive at the People Committee. I think I would support what Paula said in the fact that we've still got to try and hone the updating and the reporting further. Some of the anecdotes and the stories were brilliant, and the question for me is how do we align that with some of the actual data to present a joined up view and a joined up update on what's happening. And then the second point I'd like to make is the other thing that struck me was the real need to align everything. So, for example, the success and the benefits realisation and becoming a real thing is dependent on a very good joined up people strategy, very good planned learning and development. And so there's a lot of stuff that we do anyway, and so the big win I think will be if we don't reinvent the wheel, if we don't duplicate, if we can manage to align what we're already reporting against and figure out how we can tie the two together, because a lot of it is already there, or is already being developed, and I think it's a great chance to fast track it if we can manage to align, and that will just take time. But it was a really good first update from the People Committee's perspective. Mark?
I think Linda's grabbed most of my points, Ingrid. I was just going to say that interdependencies as things emerge. I'm a bit biased because obviously I'm part of the evaluation group, but those interdependencies, as just described, really critical, because that will only enhance the value of this work and the benefits realised as well. But I thought it was really helpful as a kind of update as well, and I think the track of the benefits tracker at the end of the report is also very, very helpful in terms of getting a grasp of what's going on here as well. So don't change that, is what I would say.
Thank you, Glyn.
Yeah, we had a good session talk about this within the executive team about how we're sort of transitioning from being a project thing that's happening on the side to the way we do things around here. And we need to make sure that the two TMTs are owning the delivery of this, because this is an enabler to allow the TMT, the clinical divisions, to actually deliver those services. So it's really important that we get a baseline about what were things like before we made this change, and produce a counterfactual to say this is what the trajectory would have been, because this extra step has now got to move on. But that moving on will become part of our annual plan, because of our annual operating plan will be based on the changes that we know we're making. So we'll end up with a sort of memo reporting, as Paul has laid out here, that sits alongside and supports how we are delivering the annual plan. But it will start to become the enabler that is allowing us to do the improvements that we're looking at.
Any other thoughts?
I wasn't sure whether to come in now, so I must ask Tim a bit more about innovation and R&D, because they're quite big sections here, and we I think there's not that much in the report about them, so I just wanted to...
No, thank you. In reverse order, so research, as I've mentioned in other forums, is moving very strongly. It's now operating as a joint and seamless service, partly based next door if you want to go and say hello. And that includes both our funded and commercial research departments, if you like. They meet together, they plan together, and strategically they act as one. And I'm very confident that we'll be able to bring a report in April. I think it was due to come to a report to board around that. Innovation is lots of discussion has happened around innovation. It's a difficult word to define, as most of us appreciate. I think we are able to define that in the context of our group services. And I am bringing a business case to the group executive tomorrow.
Thank you. May I ask a little follow-up?
Yeah, go ahead.
Just, Tim, how are we going to engage with partners around those kind of completely interrelated bits of work? So just early thoughts on that would be good.
Yes, I think I'd perhaps defer that in terms of research to my research team, particularly Fergus Caskey, who's a director of research, will be able to describe that more articulately than I. In terms of innovation, which I'm more cited on currently, the ambition is to create an innovation hub, and partners are integral to the success of that hub, both in terms of the evaluation of potential innovation projects, ongoing support for those innovation products, and potentially allowing us to commercialise, if I dare say, some of those.
And just to say that I think invites have gone out to some colleagues. I've certainly been contacted to say, could I give some thoughts on behalf of UE to colleagues like Tim Keane and others. So that's started to emerge with some really broad brush outlines of what it could look like as a starting point.
Yeah. And we heard quite a lot about this at the last board, didn't we, with your great report on that, Tim? So, Poku.
Hey, just glancing through, there's and when I take the fourth P, which is population, and I think about the point that Martin made earlier, which is rebuilding trust with communities and populations, and I look through the realization plan and ask the question, what's the ambition there? It doesn't come through. It feels like a lot of the population points is more geared towards almost the transactional end, which is around people. How do we either recruit people from communities, or which is all obviously very important. But there is something to be said around just the community engagement in itself and how that translates through our realization plan. But I don't know if you have any reflections on that, or if I missed anything.
I think that's a really good point, actually, into where do we reflect that? I think obviously, we've got specific pieces like the health equity report that are, that's coming today, but how do we weave that in? So I think it's back to this point about how do we weave in other things that we're doing to get those specific aspects of demonstrating the engagement that we have. So it's almost like a means to an end to be able to make an ultimate impact, isn't it, on the experience and the outcomes that people have, is how are we actually engaging? But like the question that was asked earlier, and I know Matthew and the team, will have a lot of detail in that. So I'm happy to reflect on the degree to which we're reflecting that into the benefits realisation. Poku, thank you.
Maria?
I think there's a sort of underpinning fifth P, isn't there, which is our partnership work that supports the delivery of the 4P benefits. And I think our anchor institution aims and efforts probably aren't reflected sufficiently actually in some of this. Some of them are quite difficult to get meaningful in-year metrics around. They tend to be longer term. And a lot of them are around creating aspiration, ambition, differential recruitment in local deprived populations, etc., work in schools, work with preventing serious youth violence, etc., etc. Huge tranche of work going on. Not all immediately aligned to a 4P benefit, but I think we're probably not reflecting that sufficiently.
Yeah.
Okay, so thank you for that. Yeah, it's a good challenge. Okay, so thank you for raising it, because I was having a similar thought about the population P. So yes, the visibility of some of the benefit kind of measures and actions, but also where that sits governance-wise, like some of it, it's not obvious where in committees that you would park it, really. So maybe we could, great if you're going to do some further thinking on that, Paula, thank you. Shall we move on to the finance benefits update? Neil, quick overview of what's different now.
Yeah, so if I just briefly recap on the projected costs and benefits that have been reported to the board during the course of the year. And then I was going to say something very brief in terms of outlook into 26/7. So to recap, in the original cost and benefits paper approved by the board back in April, we initially expected a net cost of £2 million in 25/26. When we brought the update in September, we advised that this had been reset to have a target of breaking even in this financial year. That partly reflected the overall financial context of the group, also some of the challenges associated with achieving a 5% cost improvement plan across the organisation, and the need to avoid any risk of double count or duplication with the benefits set out in the original group case. Where we are now, and that's included in the finance chapter of the paper, we are projecting a net cost of 1.2 million in this financial year. That is included in the overall forecast outturns and part of the balanced overall position at system and trust level. And that net cost does reflect some additional expenditure in terms of some of our preparation for merger, but also some of the non-recurring costs associated with the move to single trust board and trust management teams. The point I did want to emphasise to the board that is, despite some of the restraint we've had to exercise in this financial year, we are confident in terms of the net financial benefit that we set out to achieve in 26/27. So again, to remind people, that was an expectation of £8.1 million net benefit. But as we'll describe in the full business case the board will see in February, my latest expectation is that we can overachieve on the group benefits, and the little working figure I have at the moment is a net benefit more in the region of £15 million. So that's what we will bring to the board as an aspect of the full business case.
Okay, I look forward to that. Thank you, Neil. Any thoughts on the finance part of the paper that people want to explore further? Roy?
Thanks. Thank you, Ingrid. Neil, just on that last point, 8.1, looking into 26/27, we're expecting net financial benefit of 8. Do you think we can overachieve that? Just to, can I clarify that would include, whether it's 8 or 15, that would include any additional investment that we would have to make towards sort of moving along the board, the group journey, the knowledge journey.
That's right. So the costs in 26/27 have also increased compared with what we set out in the original group case. So a couple of the main example I will use there is some of the digital investment required as part of the PTIP and the safe landing on the 1st of July. So, and again, the update will set that out at some detail. Thank you.
Great, thank you. Linda?
Yes, I was just wondering, because it mentions in the report, the front end loading aspect, but also the quantum of going from 8 to 15. What is driving that, and are we confident that we can maintain that?
Yes.
Yeah, so I'll go back, I'll use one example, is the corporate services transformation programme that in the original group benefits, group case, had a narrower range of corporate services. So it was really based on digital HR and finance coming together, and an 8% aspiration over 2 financial years. You now have all the corporate services included, estates and facilities being part of that as well, and a 12% aspiration over the 2 years. And again, this is all set out in the corporate services work that all functions been undertaken this year. So I use that as one example. The other examples could go to, again, is sort of back to some of the potential within the joint clinical strategy, clinical services coming together, and us need to pursue some of the opportunities we can see within the model hospital in terms of specialties that are currently an outlier against national benchmarking, and taking advantage of coming together to improve that relative position.
Understood. Thank you.
Sure.
Just looking at the benefits now on page 12, which is the document, so that little table we've got of the 3.6 and the 2.4, obviously there are a couple of elements there that we've achieved no income against at all this year. I take your point, what you said earlier on about next year, but are we, maybe a rhetorical question for here, maybe something to go away with, but are we being honest enough with ourselves about that, those two streams of income for next year? Because clearly in January, we're not going to get anything substantial this financial year, but just going forward.
Yeah. So part of this is the point I made at the point we were pursuing these benefits in this financial year. The variable income line for potential was already fully captured within trust level plans, right. So it was avoiding that duplication. Now that said, all of the original group benefits are being reassessed as part of the full business case, and any learning in terms of likelihood of achievement at that level will be reset. And the other example I use around private patients, and again the board will soon see a business case in terms of aspirations. That £300,000 target will be achieved as part of MBT's financial delivery in this financial year. What we'll set out is some of the investment we need in infrastructure to support growth of net contribution in years to come. Again, that detail will be in the updates.
Okay, just finally, if I can quickly, in the bottom paragraph on that same page, we just make the comment around procurement and supplier selection, product standardisation, etc. And it's just something to take away. And it leads into something else I've been looking at previously. Just want to make sure that the clinicians are involved in that product standardisation, and it's not procurement and not kind of taking the power, if you see what I mean. We've got to make sure we've got that balance and clinicians are getting what they require.
No, I can assure you that's the plan. At the other end of the spectrum, where we have supplies that we much more simple, stationary supplies. Where we currently allow probably too much choice.
A bit more transactional, a bit more.
So it's a harder line at the simple end of the spectrum, clinical engagement at the more complex.
Brilliant. All right, lovely. Thank you, Nick. Thanks, John.
Okay, so that's a really helpful update, and it sounds like we're going to see more detail in February when we look at the full business case, but thank you for that. And Tim, the clinical strategy benefits, an update on where we are with that. Thank you.
Yeah, thank you very much. I won't rehearse a lot of the conversations I already had. So it can sometimes seem that we trip ourselves up with the ambition. So just to remind everybody that we have 3 phases to the joint clinical strategy. We are embarking on phase 1, which is to bring together 40 duplicated services as group clinical services. We're in conversations and support for 10 of those clinical services. And at the end of this month, we will have 5 clinical services that are operating as a group. They are ranging in complexity and scale, from trauma and orthopaedics right through to liaison psychiatry, which is a small and very complex service. We, from the outset, asked each group clinical service as part of their first milestone to becoming a group service to set out a benefits realisation plan. We have allowed clinicians, doctors, nurses, and other allied health professionals to determine that benefits realisation plan, and we have given them SMART principles, capital SMART, to do that, which means that they are very specific, they are granular, but they are meaningful and impactful, and in the paper you will see that demonstrated in cardiology. They are broadly allied to the 4 Ps. So it's our intention to now as we become mature in our approach to group clinical services, and perhaps having 8 to 10 clinical services operating as a group, to bring those benefits together and to provide this board with reassurance that they are those 4 Ps are being satisfied in the benefits which are realised. This is work monitored through the Quality and Outcomes Committee, by the way. So we're not doing this in sort of isolation. Moving on, we've still got a lot of work to do, and if anything, I would admit we are slightly behind pace. And one of our focuses in 2026 is to increase that pace. With some renewed governance, conversations have taken place between the 2 trust management teams and the Joint Clinical Strategy Board to ensure that services, as they enter the programme, are supported for a period of time, and then the delivery, as Glyn has already alluded to, is much more ingrained in the business of trust management teams in the current structure. You'll be aware that we had a very, very engaged partnership event on the 4th of November, and the output of that will be published early in February. And really the output of that focuses in 3 different directions. Output number 1 is a refreshment piece. That's to allow us to learn from the services to date and to increase the speed and penetration of the delivery of the rest of the group clinical services. If you like, it's slightly internal facing. The second part of that output is about reframing our group clinical services to take into account some of the issues we've discussed today. What is the impact on populations? How do the benefits leave the acute hospital and are felt more widely in our communities? And the third aspect of our update is to start to reimagine what healthcare might look like over a 5-year course and a 5 to 10 year projection, because that reimagination will be so critical for us to frame what our future will look like and the next iteration of our clinical strategy. And that will be with deeper and more complex integration with communities, neighbourhoods and our partners. What else can I say? Just one other point really, if I may. There is a piece of work which we are very conscious is critical to the delivery of the Joint Clinical Strategy, and that's our diagnostic piece. And we do have a plan to dive deeply into outpatients, into theatres and into other aspects such as our estate, to really understand what our current situation is, benchmark, what the future could look like, and particularly what levelling across might realise in terms of benefits. Thank you.
Okay, thank you very much, Tim. Gosh, so this is the core purpose behind pretty much all we've been doing, so it's really, really good to hear that update, Tim. Thank you. Anything today that people would want to follow up? Roy?
Thank you, Tim, thank you. Just on the quantitative benefits, it's really good to have that table that shows the milestones and the smart measures that you're speaking about. I think that's great that the guidance has been clearly set. I was wondering 2 questions really. One is the standards or the milestones that we're heading towards is when do we expect to get to that point? Is that a 26-27 thing? Is that 25-26? I think that could be, if you could clarify that would be helpful. And then also for cardiology, for example, which is the first joint service, has been going for a while. How are we tracking towards that goal? Because surely we know a little bit about where we are, and I think you mentioned we may be behind, but just some flavour on that would be helpful.
Yeah, so I'll start off at the cardiology. So we're blessed with cardiology. So there is they benchmarked very clearly what their benefits could be, and there's a trajectory to deliver that by 2027 in terms of real, tangible, noticeable patient and user and staff benefits. We are supported by an evaluation process of which I have remained very independent because I don't want to influence it or anything of that nature. So we are reliant on an external evaluation process to really guide us as to the success of our methodology. I think I'm picking up one potential, not a criticism, Roy, but an observation, is that we haven't been particularly rigorous in knowing when a group clinical service, we can call it a success, in terms of what is the scale of benefits that we are looking for. We have not really set that trajectory, apart from vague, broad statements such as they should be seamless, they should be equitable, etc., etc. So I think there is more work to do to define that moving forward. In terms of the milestones you referred to in the first part of your question, are you looking at the 3 milestones for a group service? So all
No, so you know, for example, cardiology, 100% of patients seen within 2 weeks. That's the end goal.
Yeah.
I was just wondering where we are on that at the moment. Are we sort of
the-
making progress towards the 100%?
So we are making progress with a view to delivery by 2027. So over the course of this year, those standards we expect to be met.
Yeah, quick point from Maria, and I'm conscious of time, colleagues.
I suppose at some point perhaps a conversation about realistic expectations around some of this, because there is, you know, we can look at access, for example, but in terms of outcomes, that's a much longer trajectory. So as we look at milestones, I'm just trying to not set you up for saying, you know, everyone's going to, you know, have fantastic tickers by 2027. Just, you know, what clinically we feel is a really good, acceptable set of outcomes that we can see over time, so we know services are improving. Access, etc., is all part of it. But there's also the longer term view, isn't there? So how we get that as a reasonable milestone, which the board wouldn't expect to see every month, for example. It might be a 5-year cut that we'd be reviewing.
Yeah, I think that's a challenge. I think the problem, if we've got a problem, it's that each service has set its own benefits framework, if you like. So it's quite hard to compare and contrast. You'll get cardiology, which has been very specific, and they do think they are all achievable, and you'll get other services which give us benefits which, quite frankly, currently I don't know how to measure. So I think there is a degree of variance and flexibility amongst those clinical services in the benefits, which I think has been a conversation we were having last week, I think at our one of our strategy sessions, and a conversation which is ongoing to try to standardise. But you know, I can't. The point you're making is we don't want to overpromise here. These need to be realistic. So there's a balance between granular, the number of patients who are waiting for a PCI across the various sites, as opposed to sort of global, you know, we've cured cancer kind of thing. So there is a scale here that we need to pitch about right, which is acceptable to this board, but increasingly to our community.
So I knew this would happen. We are way overrunning on this item, but it's really, really important. So I don't want to cut us off. So bear with, folks. We'll hopefully make up the time later on the agenda. Paula, I can see you're itching to come in, and Sue and Glyn are also. Wait, were you coming in as a response?
It was really just about, I think the challenge is exactly what's been described. It's having the clear trajectories. It's starting to report performance against it. That, you know, overtly here is said this is the gap, and some things we will be able to report performance on quite early, but as a step towards these bigger ambitions, and some will take longer to actually craft the right measures, which is why we're working with Health Innovation Network West of England to really help us with that independent view as to what the specific kind of impacts, particularly on patients and people, are, what are the secret ingredients that help us move towards it. So I think until we start to report on actual performance, it's really difficult for the board to gauge are we on or off track.
Okay, so point noted.
This is really,
Glyn, and then we're going to have to come to
it's really quick in terms of it is really difficult when you want to engage clinical teams and they come up. So have you considered about GIRFT or a benchmarking attached to each of the services, because that would give us, because we don't want just to be what we perceive to the best, we want to be the best performing. So is there benchmarking against the best nationally and GERFed in consideration.
There is. So that's where we start really, is there a GERF report? We share them across the two organisations, compare and contrast, look for the opportunities. Is there a national standard? Is there a regulatory standard? So that we start off with the barrier, with the the what we aspire to be.
It would be really helpful, I think, to be really explicit about that. Thank you.
There's an accountability framework piece of which is what the Joint Clinical Strategy team, it's what they have designed, and it's the first thing that's the first milestone. Is we'll sit down, we'll look at what the data tells us, and we'll look at where the opportunity is, and we'll look at the best in class and what we think we can achieve.
Thank you.
Okay, and Glyn, last word.
Yeah, it's building on what I said earlier about the fact that the TMTs and particularly the COOs need to start to get engaged with this, because if you take the cardiology thing where UHBW had about a 2 week wait, we had about a 6 week wait. Some of that will now be built into this year's annual plan, but it will be based around literally how many clinicians are there to be able to do what activity on what sites, etc., and be really built into a detailed granular operational delivery plan that the board will be able to see progress against, are we achieving those things that are there. And the bit where I talk about being a memo bit of measure, we need to sort of say, well, we said we're going to improve by 4 weeks. There is 2 weeks improvement built into this year's annual plan that will be measured against, reported again in great granularity every month. The other 2 weeks is still owed, and how are we going to get that next year in the next annual plan? So it's taking that almost theoretical top down, we want to make this improvement. Now we need to bake it into the hard wiring of the thing that we know is how we deliver.
Yeah, absolutely. So making it business as usual in that. Okay, let us turn then to the recommendation. So the paper is for note, and in particular, Paula highlighting that we'll hear again in May, as a whole board, a revised and refined benefits report, and that in the meantime, some of this will be going through committees as well. So we're being asked to note the progress to date with establishing the group benefit plan, including the early wins and the financial benefits, to note the intention to develop an aggregated dashboard for benefits delivery reporting, and we'll amp up the population P bit in that, I think, yeah. And then progress on the clinical and corporate. So we haven't even talked about the people bit, but it's very clear there in the dashboard, Jenny, so noted and thank you. So progress on clinical and corporate services transformation, implementation and next steps. So noting all of that, I think we can have a quick break. Okay, let's move on then to the integrated performance and quality report, and we'll start as usual with the access part of it. So over to Glyn and Stu to any highlights. We'll take it as largely read, but anything you particularly want us to pay attention to.
So shall I go first?
Yeah, go for it, Stu. Yeah.
Well, if I start with unscheduled care, I think the current pressures in the system are well recognised. I think it's worth saying, you know, the report covers the data up until the end of November. The current situation is that UHBW remains in critical incident on the basis of its unscheduled care situation.
Yeah.
We have today over 220 no criteria to reside patients and 130 escalation area beds open, 130 or so, reminding people that of those probably 40 to 45 are actual bed spaces with a bed, and the rest is areas where we've had to manufacture additional spaces. Obviously the patient experience in association with that is challenged. However, and that is an ongoing situation being managed very directly by a combination of ourselves, colleagues in MBT, we've been working together very closely on this, plus multiple stakeholders across our health and care system, and with very strong support from our ICB. And so it is a very challenged environment. The 4-hour performance and the 12-hour performance you see in the report does not achieve the standard, but is, I think, a good response to the operational challenges that we face. I do have a number of provisional data to add in for December, but they are all provisional, so I'll just ask people note that there's final ratification to be made of all of them. But nevertheless, the December 4 and 12-hour performance are pretty much the same. And so, slight improvement, but 0.1 of a percent type, type improvements, but pretty much exactly the same. The THP, which is the SWAST ambulance handover process, has been implemented in this in the figures that you're seeing, and of course that does have a direct consequence on ambulance handover times, and you can see they have significantly improved. There's no surprise there. That's what the policy does. But I think it is also worth flagging up that has a direct knock-on consequence to our own ability to deliver, especially in terms of the 4 and 12-hour performance standards. With elective care, for 65 weeks, people will know that our aspiration was to achieve eradication of 65-week waiters by the end of December. And we were very, very close in the data presented for November, but I can confirm that we have achieved that for December. We also remain on trajectory to deliver less than 1% 52-week waiters by the end of March, although I must say there remains some risk in that, principally as previously related to a significant degree to dental provision. The diagnostic situation is as described. The cancer situation, we have achieved the 31 and 62-day standards in the report. I'll give people the heads up, there might be a blip in the 31-day standards in December related to some chemotherapy delays, but we are on that, and I think already resolved it, but just to give people the heads up that may be coming through. And the FDS status, again, we were just short in the numbers presented, but I can confirm that the provisional results for December show that, as we predicted, we have resolved that deviation from the required standard for the faster diagnostic standard. So overall, I would say a really strong performance, actually, I think it's fair to say, in the context of some very, very significant operational pressures, especially in the unscheduled care arena.
Okay.
I think that'd be my summary.
Yeah, thank you. And easy to see, therefore, why UHBW is segment 1, because of the strength of the performance, other than the ED weights, which we all understand. Glyn,
yes.
MBT.
Yes, I won't repeat all of the similar pressures around UEC that we had, and whilst we came out of CI yesterday, that was because we'd got out of 60 of the 160 escalation beds that we had open at the peak of the critical incident. So we are currently in Opal 4 and a high Opal 4 as we're working to try and get the discharges flowing that we need. Similarly, our 4-hour UEC performance remained fairly. It was a step up in November, a 4-point step up from the previous month, and in December we held that. And that's actually 10% higher than it was in the same period last year. So we are, whilst not achieving the constitutional standard and the targets we want to get there, we are showing continued improvements there. In terms of RTT for 18-week, we are holding at 66%, and we have an improvement plan that we are confident will get us up to the 72% target for the end of the year. Cancer 62-day performance, which is the one that that we are really targeted and measured on, again saw a almost 4% improvement month on month, up to almost 67%, and again in December, with early figures there are that we're going to show continued improvement up to 70% in December. Diagnostics, we continue to be very close to the 1% target, and in terms of 65-week waits, we have 2 patients that are awaiting DF surgery, so breast reconstruction surgery. We've had issues around consultant sickness and consultant availability that we are working with NHSE. They're comfortable with our recovery plan. We hope to have those completed by the end of the year. In terms of the 52-week wait, we're already less than 1%, which is the target for this year. We're now below 100. We're at 91 patients waiting more than 52 weeks, and we are confident that we'll all but eradicate that by the end of this this financial year. There'll be some issues around the DEP of surgery, but again, by the time we get to Q2 next year, that will be eradicated, and so we are aiming then, we're starting to look at the 48-week cohort and trying to eat into that. The one thing I would say around UEC is that we often talk about the ED and the volume of people coming in through ED. What we have seen is that between December and January, we're seeing a 26% increase in GP referrals, so direct admits onto our AMU and advanced frailty units, a 26% increase in the number of referrals, and they are appropriate referrals because these are people who are coming in and being admitted. So it's not that it is poor system working. There is something happening with a respiratory and frailty even more than we usually get at this time of year.
Thank you very much, Glyn. So again, overall, amazing performance given the pressures, but it's no criteria to reside in both cases that is driving the difficulties. And again, we can see in the report we're being promised jam tomorrow, frankly, aren't we, in terms of ICS discharge programme. So I suggest we take this to this afternoon for a conversation further, because it cannot go on like this, with both trusts being in critical incident for an extended period as a result. So let's save our conversation till later, if that's okay, because we can have a full and frank in that environment.
It was a very small point just to say, when you mentioned about the respiratory and frailty kind of uptick, if you like, that's where the data analytics and that's where the kind of insights from other kind of aspects of the system might give some breadcrumbs to why this is happening. Is it normal for this area as opposed to other parts of the country, and how do you use data to actually help mitigate that? And there's been some reports of that recently, hasn't there, in the news, of where the insights have been used to then get the workflow of either staff or systems in place. I'm not saying it's the magic bullet, Glyn, but I think that's where getting smart with data and analytics is important.
Mm-hmm. Okay. To respond now or take away?
No, take away.
Take away. And Richard?
I'm just trying to triangulate these individual results with the NOF and our Category 1, Category 2 position. Moving into quarter 3, the critical incidents that we're experiencing, are those, do we think, likely to impact our standing or not? Everyone else is in the same boat, basically.
Exactly. So they are relative score. They are relative performance metrics, and we are focusing on and achieving the things that we need to. So we both held 95% elective activity during the industrial action. I think we cancelled something like 22 cases during our industrial action, 22 elective cases, and those are being rescheduled as we speak to recover, to make sure that we don't get impacted by that. The financial position is one of the drivers, and Neil will come on to that now, but that's looking in a relatively good position for the end of the quarter as well.
Thank you. Shall we move on to quality? So over to you, Steve. Things that we need to pay attention to.
Yeah, just 3 things, if I may, Chair. Firstly, the colleagues will notice the pressure injury rise in both organisations actually over the last couple of months. Pleased to say that December is looking much better, but there's improvement work going on across both organisations to ensure we appropriately assess and therefore look after patients to reduce pressure injuries. We will establish the cross-city improvement collaborative around pressure ulcers, principally for us, but the connections into our communities will be incredibly important there as well, given that many patients do come in with pressure injuries. So that will progress over this next quarter. E. coli has been added, so we're now tracking the 3 principal bugs that were held to account on. And also the PQSM is there for both organisations. PQSM is reviewed by Quality Committee at a fair degree of scrutiny, but nothing to particularly add other than to note that both of them are there. Very happy to take questions on any other issues.
Anything to highlight from this?
It was really probably for Tim about the fractured neck of femur. And it was interesting because you're saying that trauma and orthopaedics would be one of the new joint services, clinical services. But both trusts really are still not doing brilliantly. Particularly it's around treated within 36 hours, and it says here it's about the extra theatre space is being created. And I know this is November, but I'm just wondering, have you seen any improvement in December? Or are we likely to see?
So I think we got an improvement started in November actually. I think is that the data?
We've got November data here.
Not loading on. It started improving in November in both organisations. I haven't seen the December.
Okay. It's just, it's one of the measures and quality measures. If you are a patient waiting for surgery, it is really, really distressing, and it's something that we've monitored for a long time, and we just don't seem to be able to see an improvements. But if you've got an improvement plan,
we've got an improvement plan. I think always with fractured neck femur is as you'll realise is not necessarily access to the theatre. It is compounded as well by lots of other factors, including sort of the availability of beds and the appropriate beds for patients to recover from. So it's quite a complex metric. I think whilst we definitely have seen an improvement in December, then notwithstanding the comments made by my colleagues Stuart and Glyn, we might see that not sustained in the current month because of bed impacts.
Okay, I suppose my follow-up is, by the new joint service, do you think that will have an impact in terms of the way?
It's one of their benefits that they are working on.
Okay,
in fact, was captured in Paula's work then. Excellent. Okay, on to people then, Jenny. Anything to highlight from this section?
Yes, 3 exceptions, please. Just to reference the vacancies in both organisations. And I guess that needs to be taken as well as part of the overall whole time equivalent plan as well. So what you'll see is some of this then offset by bank and agency. So you can see the actions being taken in here. I think the really important piece is the team are doing a deep dive into the workforce plan at the minute, just to make sure that we have got our assumptions right rolling forward into this year's submission, and to make sure that the actions we'd plan to take are on track. So I'll pick that up through the people committee later in the month. Excuse me, I'm really croaky today. The second one I would want to raise would be sickness, particularly in MBT. But again, you can see a worsening position in both organisations. What we're seeing when we look at the data is most of that is around long-term sickness. So we're doing quite a bit of work with the various different divisions to establish whether there is anything that we can do with that. Some of that is harder to do, but the team are going through the cases with managers on an individual case-by-case basis. And then I guess finally the other one I would want to flag is where we are with our mandatory and statutory training. You can see there's several areas that are not hitting our own target, but are actually compliant with external targets. The one I'm more worried about is the Oliver McGowan training. You'd flagged to me in the last board that there were issues with being able to access, and also not just the ability to be able to get onto the system, but also then the capacity to meet the demand. That's been resolved, but you can see for both organisations we are some way off the end of year target. So I've asked the team, in addition to the actions that are in here, to provide me the weekly trajectory so that I can see the improvement that we are hoping to make. And then when we're not, I can take earlier action in order to be able to make sure that we're doing everything we can. I guess it's, I will just call out that the pressures we've just talked about will mean that we are not encouraging our staff to be doing this training when we also need them to be delivering the care in the situations that Glyn and Stuart have just described. So a bit of a tension in there, I think, which is why I want to see where we are against the trajectory.
Okay, thank you. Anything to pick up from that section of the report? Glyn?
Just a quick qualifier. Whereas in a steady state organisation, you might see high vacancies as an issue about lack of planning or whatever else. We're consciously driving this up in some areas. We've had recruitment freezes in the corporate service functions, etc. So we are consciously driving up some of this as we move towards reducing the workforce.
So it's intention.
Yeah. Some of it. Yeah.
Some of it. Yeah. Okay. Thank you.
But that will be felt in the clinical areas by obviously graduates and the like, if any freezes are happening there, just to say that impact of the graduates coming out from universities, part of the workforce. So we are seeing that though as well, as a challenge, and then that's meaning they can't stay locally. Yeah. I mean, it's hard to stay locally anyway because of the prices of houses and things, but there is an impact there on the clinical based workforce. It's just to say we are seeing that.
Understood. Thank you. Shall we move on to finance, Neil?
Yep, thank you. So the report is to the end of November, but as usual with the timing of the board, I can bring the board up to date in terms of the position at the end of December. Just to draw out content that's within the report. So at the end of November, we were 3.5 million adrift from plan, and that could be entirely attributed to both the costs and the loss of income associated with the previous bouts of industrial action. 8 months into the financial year, key themes being the costs of escalated capacity. There's a savings shortfall in MBT that is offset by the vacancies that we've just mentioned, and some pressures on UHBW pay budgets. I did want to highlight UHBW on track to deliver a £53 million savings target, so 5%. But along with MBT, an issue in terms of savings identified on a recurring basis that will, of course, impact on the requirements in 26-27. To bring us up to date, so at the end of month 9, both trusts are now back on plan. So in absolute terms, that's a deficit of 2.6 million in MBT, so a £2 million improvement on the previous month, 9.3 million in UHBW, 1.7 million in improvement. And again, this can be directly related to an additional allocation in December of just over £4 million. So this is an NHSE allocation to offset the costs of industrial action in November, December. So there's no funding to cover the loss of income, but there is a source of funding to cover those costs. So that's helped us get back on trajectory at the end of Q3. The final point I was going to make, and again it links back to some of the conversation we've had around operational pressures. So whilst the system and the trusts continue to maintain the expectation of break even at the end of the financial year, we can't ignore the risk associated with the continued costs of escalation, the impact that can have in terms of managerial clinical staff focus, coping with the here and now that can distract from the remaining financial recovery in Q4, but also the potential risk in terms of elective recovery funding. So I'm just drawing out that there's a financial risk associated with the operational concerns earlier expressed. At this point in time, that doesn't lead us to believe that we will not achieve the break-even plan.
Okay, thank you very much. Anything to pick up from the finance position? Great, we're back on track, albeit for the reason you gave. All right, in which case the report is for information, and obviously we'll be picking up what the committee's had to say about some of these things as well as we go through the agenda. So, Catherine, the health equity plan. Steve and Tim, I think you're due to do a brief intro.
Yeah. Shall I kick off? So Catherine will Catherine probably doesn't need introduction to everybody. Catherine is a consultant in public health who is employed by the Bristol NHS Group. That's an unusual thing for an acute organisation to be proud of, but we are extremely proud of it. And in fact, Catherine's been joined by a registrar very recently. And we hope that becomes one of our growing teams or specialisations within our group. So if anyone is got any doubt why we are discussing this, and we are discussing it again so soon after this came to board in November.
That was the people-y one. That was the anti-racism one that was mostly entirely focused about colleagues. So this is kind of the flip side of it. It's the other side of the coin, which is externally facing into impact on populations.
Indeed, and certainly this item's also been discussed in Quality and Outcome Committee, and also by the group executive. But if anyone's in any doubt, I think it's page 156 of Convene, and if you're not blessed with Convene, page 156 is a slide which I think Catherine will show you demonstrating the effect that inequity and inequality has on your life expectancy in Bristol, North Somerset and South Gloucestershire. So health equity is everybody's business. It's very important that we do this together to harness the benefits of two large organisations. And again, Catherine will explain how we've moved from two equity programmes into one delivery programme, and also how important health equity is for our engagement with and a deep understanding of the communities that we serve. So Catherine, I think we've got to turn around. Is that right? Can you tell us where the slides are?
Yeah.
Are they behind us?
I think most of us have got them on Convene anyway, haven't we? So don't worry.
I mean, I'm not going to spend very long talking. Thank you very much for having me here today. I think what I would like to do is just share something around the terminology and the language that we're using in this, respond to some of the themes that have been raised here already this morning, and I hear this plan is being discussed against those, which is really fantastic actually, and then just acknowledge the direction of travel and where this plan is hopefully going to take us to. So there's no need to turn around if you're not able to, but if you are able to see across there, much of this is just reflected in the plan. So just in terms of language and definitions, because you hear different terms talked about quite frequently, health inequalities obviously are unfair and avoidable differences in health between different population groups, and part of what contributes to that is your healthcare inequalities, which is differences in access, outcomes and experience, and on average that will contribute around 20% of a population's health. Now we are the specialist providers of that healthcare, so that is a really big proportion of our population's health that we have the ability to positively influence, and a responsibility there. But we also acknowledge that other 80%, the social determinants of health, the environments in which we are born, grow, live and work, very, very relevant for our nearly 30,000 staff members, but also as an anchor in our community, a large buyer of services, a recruiter, and all of that. It becomes sort of a wider responsibility around that. And why do we talk about health equity versus health inequalities? Now, health equity is the positive approach to this, where people get the resources that are distributed according to need, in this case maybe to be able to access our healthcare services. And you can see that reflected in the middle picture there, where if we give everybody the same level of support, that won't have the impact that we're seeking to have. So that's why we talk about health equity as striving towards that positive situation where we're also responsible and able to have that influence on the structural inequalities that create those barriers and that need. And I think we heard a lot about that in the patient story first off this morning. The other term that you'll hear is population health, and that is improving health outcomes across our population groups. So health equity is part of that, but we also need to bring a focus on prevention of ill health. And it's when we bring these things together
that we really start to see that impact for our populations. So I think it was just important to go through that, because we hear different terms discussed, and you could see what you have in front of you as a population health plan or a health equity plan, and I would be comfortable with both those terms being used. It is a pillar of our joint clinical strategy as it stands now, and really the emphasis behind the 3 shifts that you see in the 10-year plan is around improving health outcomes. These are levers to deliver that improvement. And I think when we're mindful of that, it becomes clear why you need that focus on population health and health equity in the work that we're doing in the next stages with the joint clinical strategy and the response to the 10-year plan themes. This is in the plan, and it's just really to recognise that we've come a long way with health equity work, particularly since COVID shone a light on this around 5 or 6 years ago now, from the establishment of 2 steering groups, the recruitment of community partners to those health equity steering group at UHBW, to a progressive alignment and working on joint projects, and then now having a joint plan that will carry us on with this important work, and the establishment of the joint health equity delivery group, which will meet for the first time next month and will carry on this important work and report upwards to the Quality and Outcome Committee. And there is an invitation to anybody in this room that would like to attend that health equity delivery group at some point this year to come and experience that. Now, we do recognise that what we've written here is a 1-year plan, and we know that there's a need for a longer term plan, but it was important to continue this work through this stage of merger and recognise that that longer term approach needs to be properly co-produced with our communities and with our community partners, and that we need time to do that work. So you will see that quite a lot has gone into developing this plan in terms of engagement sessions, including with the board and with our community partners and with our system colleagues. And there's definitely more to do around that. But we also recognise that we have lots of passionate, engaged staff in our organisations working on health inequalities in their services or from their communities. So we haven't captured all of that work here, but what we really want to do is enable that as a corporate central function so that our staff have the skills and the capability to respond to that and support that work. So it's just to acknowledge that there is a real breadth of work happening here. We've described our 4 goals for health equity, and what you will see under these is that each of the 4 goals has areas that we need to be delivering on and functions that will sit under those across access to our services, designing and delivering with communities, strengthening our capability as organisations to deliver on this, and crucially thinking about our role as an anchor organisation and bringing in that perspective on staff and people, and recognising that they face very much the same health inequalities as our patients do. And I think it's important to look at it in this context and really the multifaceted approach that you need to build on health equity. And I would describe this as a population health approach and acknowledge that it is both an art and a science, and that the partnership work really needs to underpin this. And it is also a journey, and we will sort of continue on that journey and continue learning through the next year, and as we build upon this work. Data and intelligence has been mentioned multiple times, and that's critical to make better use and take that data-led approach. And we're working on the IQPR report for the board containing a few key inequality metrics so that there is that visibility at board level, as we are working on our community engagement and bringing that voice of lived experience, and that's very relevant to the conversations earlier about trust, for instance. So very much seeking to do this work in partnership with our community partners, with the voluntary sector, with the locality partnerships, with our system colleagues, and recognise that the work that it takes to build those equitable partnerships. We have included in here some key year one measures of success. These are reflective of the priorities that we know we need to build upon in terms of progress and prepare us for the next steps. I think what we would like in the next stage of this work over the next year is that longer term focus on health outcomes, as you referred to earlier, Maria, and acknowledging the time that it takes to start to move the dial on those, but very much preparing us for those next steps. And I think the use of data and intelligence, whether that's insights from our communities or population demographics, is something that can really support the organisation, not just from a health equity focus, but also from that performance and operational focus. And our longer term plans, I won't read this out, but you've got it in your set, again, is that we will be looking to build that longer term plan over the next year. Very close alignment between population health and health equity with our joint clinical strategy work, and very much welcome that. And that trust and community engagement and partnership is going to be really foundational to this. And we will be continuing community representation into our health equity delivery group and seeking to work closely with the community participation group and other forums for really listening and learning from our patients' experience as we look to co-produce that longer term delivery plan. So that was all I was going to say.
Thank you very much indeed. It's really impressive. Thank you. And anything that people would like to explore further? Maria?
Thank you very much. I'm absolutely delighted you're here and the registrar and we're doing this sort of work. So a couple of points. One is the alignment with our local authority council strategies as well, because those wider determinants of health, how and where you're born and brought up, are so pivotal to how you end up accessing services and your outcomes. But also how we will use some of this as we look at our ICB becoming a strategic commissioner for the future. So what evidence, what focus, what priorities would we ask them to have as they move into their multi-year strategic commissioning framework, recognising, you know, there's always a balance, isn't there? If we're saying we'd like everything to be equal, let's put all our money into children's first 1,000 days, where we can really try to equalise from the start. But of course we can't do that because we're taking money away from lots of different groups. So a couple of points: how will we link and make sure that we're aligning these conversations? And I know there are lots of forums with Christine, for example, at Bristol. And then secondly, what would be perhaps one or two areas we'd say to our ICB, would really like you to focus on this, because we think in terms of hospital services, these are really inequitable areas.
Thank you for the question. So we have formally consulted with our 3 directors of public health for BNSSG on this plan, and very much work to align it with the health and wellbeing strategies and also with the joint forward plan and planning from the ICB. So it should reflect shared priorities there. And I think it's important that we continue to really engage in those forums with our directors of public health and population health within the ICB as we go forwards. I think there's a very useful report recently published from the ICB looking at access to healthcare, including in our acute trust. And I think making use of data and intelligence like that in our organisations is a key step around that. I think in terms of priority areas to feed into the strategic commissioning, I mean, I think it's an opportunity now to work with the ICB as those structures and approaches in population health management, which is the use and of data and intelligence, and also the population health function that will sit with the ICB in terms of what that will look like and how it will support our work. So I think there are some key areas, and we know our leading drivers of inequality in terms of health outcomes are cardiovascular disease and cancer. So I think a really strong focus on those is merited, but alongside that, not to overlook the other way of cutting this, which would be to, for instance, look at urgent and emergency care access, outcomes and experience, so not to lose sight on that side of operational performance and where inequalities features in that, which you would see much more of in that recent report, for instance. So I think those conversations are very live at the moment. And there may be, as I talked about at the beginning, different language and terminology used, but I think the priorities are there. And I think in the future, with the strategic commissioning framework and potentially integrated healthcare organisations, you'd see much more of an emphasis on this shared approach to population health outcomes.
Yeah, I mean, I suppose I'm just thinking of a world in which group cardiac services are focused on an ICB priority, which is the higher incidence and poorer outcomes of the Gypsy, Roma and Traveller community, for example. So how we would really use the group lens to try and make a difference in a particular area. So just kind of making a tangible connection somehow with what we're trying to do. Might be something to look at, Tim, when we look at our outcomes, not just access, but targeted access.
Yeah. Again, there's very smart, there's very specific, specific benefits that we can pull through. And also just to say, I think it's important to point out that this is an important piece of work, and it forms really part of the data set, if you like, that helps us to write our next iteration of our clinical strategy. It is part of that framework for the future, and it's pretty integral to that in terms of the document library that we will be using to form that.
So we've got now 5 hands, and again we are way behind time, people. I'm hoping we can catch up. This is the last substantive item, so I'm hoping we can sort of catch up in the next few, so we'll let it run a little bit. But Mark, Roy, then Jenny, then Martin and Pokey. So
I'll be very quick, Chair.
Off you go. Good.
Catherine, I think this is a great report, and really finally listening to the patient story this morning, you can see what something like this means in that environment. There's 2 points similar to what Maria said around local authorities. I do worry about the local authority connection through. We both belong to the Bristol Race and Health Equity Group. I always get equity and quality mixed up, but this speaks to that so well. So some of the things you mentioned about the Gypsy Roma Traveller kind of conditions and things, Maria, that speaks to that. We have to be kind of embedded and vice versa, and that's why pulling through to the One City plan where something like this could really, really help. My other question, just a thought, is again going back to this morning, how does the culture follow this or inform this to take the people with us across the group structure to really make sure we embed something like this at the heart of everything that we do? That's a massive question, but I'm just thinking that we have to help translate this, don't we, into the people environment to be owned by the people. As you say, it's everyone's business as well, but I think it's an excellent progression on in this particular space. So well done.
Jenny, do you want to come next? Because I imagine you might follow through on that point.
Mine was going to be a different point actually, but happy to pick that one up. No, it's so I think it's the tangible work that people like Tim and his team are doing, where it's really explicit for the clinical teams about where we're expecting health equity improvements and outcomes to sit within their clinical services. That is what I think makes it real. There is training in here and education is important, but I think that piece where you get teams to really start to think about and understand this from their own service perspective makes it the most real. So I think that explicit expectation that we're setting in all of those 40 work streams is probably the most crucial action we can take in that culture space.
Excellent.
Thank you. And Roy?
Thanks, Ingrid. I'll be quick as well. I think this is great. I'm 100% behind. Population health is the way forward. I think my general point is probably around pace, because there are some things that are outside of our control or require stakeholders, but there's some things that are entirely within our control. And so how do we separate the ones, improved recording of ethnicity trust-wide is something we can do ourselves straight away if we put the right pieces in. So being able to do the bits, because let's not let perfection be the enemy of the good. You won't be able to do everything at one time. I'm just conscious that health equity is something we've committed to as a June of last year as a group. We said we want to do this. UHPW, we committed to it. Core 20 plus 5 is coming up to 5 years old. So I want to be able to show incremental progress around health equity and then not wait for all the ducks to be lined up and then sort of tackle it together. So
great, thank you, Roy. And I think Martin was next.
Yeah, just quickly, I was actually following up on Maria's point about alignment with ICB stroke local government, and I think obviously we need to consider the next tier down, i.e. neighbourhood health, and not totally familiar with the ICB approach to that here, but I suppose our challenge is how we key into that to make sure we are delivering neighbourhood health where we can, and probably, given the inequality and the equality point, we're not necessarily providing the same service to every locality. And I know sometimes it'd be different when you've got 16 different localities all want slightly different things from a particular consultant body, but how we give ourselves permission, I suppose, to do that. And I think looking at the clinical strategy work that's being uploaded soon, we are already making those steps, I think, in terms of showing how we're going to link into neighbourhood health, which is a great start, I think.
Thank you, Martin.
I'm not sure Jenny got to make a
Oh,
point,
Jenny,
actually.
did I cut you off in
No.
that rhyme? I'm so sorry. Do you want to come back?
So it was just to say, Catherine and I are going to meet because actually I'm quite keen to try and strengthen some of the staff aspects in this plan. I really reflect that anything really outside of the area of discrimination, probably the universal offer that we provide, which is the case right across the NHS, is probably in itself widening those gaps within our own people's health outcomes. So I'm really keen. This is not an area of expertise for me, but it's an area of passion. So I'm hoping we can glue those two things together. I think this is a brilliant start, but if I can work with you just to strengthen the longer term piece and help my team, bring them along with us, I think that would be hugely helpful to do from our own people's perspective.
Good offer. Thank you very much, Jenny. Poku.
Hopefully I'll be concise. There's a point about, so there's no doubt with the 3 shifts and the 10-year plan that this is important, like you rightly said. And maybe this is a point that you already made, albeit a bit lightly, which is to say, when we think about the strategic and the governance framework for how we hold this at board level, it's still unclear. I know that you made an invitation that when it comes to the health equity, UHBW health equity group, you invite one of us to sit on. But was that right? Did I hear that right?
Well, we are meeting as a joint health equity delivery group across the group now, and we're meeting for the first time next month. You still need to develop the terms. It will report upwards to Quality and Outcome Committee, but as a starter, I think if you would like to attend or anybody else, it would be very welcome to come and see the work that we're doing and think about membership.
Yeah. So in some parts. So maybe there's more work to be done to make sure that our oversight of that is greater. But also to echo, I think Jenny, if I hear what Jenny's point was, it's a bit around when I look at the plan. There's obviously some effort has gone into training and skills and things of that nature. But I think we need to think more vertical development. Not to say that it's not being considered, but this is a way of working, isn't it? It's a way of looking at how we approach work in its totality. So there needs to be. It feels to me that there needs to be a bit more concentration on vertical development. So not just, equipping people with skills, but how do you change the minds? So that was my only point.
Yeah. Which was what we heard from Adira earlier, wasn't it? Very much about attitudes and beliefs about people. Yeah. Okay, thank you. I think we are at an end to the inputs from colleagues. So thank you very much, Catherine. And it was great to see the work that the board did back in June, I think it was, very much reflected in this plan as well. So thank you for that. So that gives us the assurance that we weren't just talking into the wind that day. It is actually landing in the real world as something that we are committed to and will want to support the progress. So we're being asked to endorse the approach, which I think we broadly are, and wanting to maybe see some finessing, see some visibility about delivery and governance around it. But we will see a report back to board on the year one deliverables, I would imagine. So it's good that we've got clear year one actions for each of the 4 areas in the plan. And then the long-term approach, which is about co-production with others, sounds utterly on the button to me. So we'll hear more from you, I'm sure. Thank you very much indeed. And thank you for your work on it. Right, we're going to get some pace now, folks, because we've got some things that I hope we can do relatively quickly. Learning from deaths, we did a big item on in September. We are required to have this visible at board, so it has come in this form this time, but hitherto will get subsumed in a shorter format into the IQPR. But for today, Tim, it looks like it's all on track. Anything that we need to be aware of?
No, we remain as a group a very safe place to be treated. Deaths are inevitable, hospital deaths are expected. We scrutinise hospital deaths for learning and opportunities to improve. We're ahead of the many other organisations, including the rollout of our medical examiner service. I would recommend that this board could be assured that we take every opportunity to learn from every death across the organisation. They presented here a number of documents. There is the quarterly report for the group from Q1 and Q2 25-26, and I do seek the approval for those documents, please.
Okay, thank you very much. Stu?
Yeah, I'm just wondering, Ingrid, if we move to an IQPR report of the learning from deaths, what are the metric? What metric are we going to put in the IQPR that could summarise all of that learning in a very succinct way? Genuine question. I'm not sure what we would actually, which one we would use.
I don't know the answer to that. I don't know if anybody Xavier to the rescue.
I don't have the answer, but what I do know is that Paul Creswell, our new group director of quality governance, is working with the Learning from Deaths team to pull together those slides. He's got Karen Brady involved as well from so I think that is in development and the proposal will come forward, but it has been discussed, and Paul, having spoken with the Learning from Deaths team, is confident that they do have a way of presenting the data in a way that will be meaningful.
So watch this space. Right, Sarah.
I just wonder if perhaps we might use quality committee as well to look at more detailed data, and I think in the past we have always seen this before it's come to board. Right. So I'd welcome that going forward.
Yeah, so could highlight to board any areas of concern within the...
I'd second that, because I think it's not just the quantitative, it's the qualitative and the learning, and I think that's really hard. I think Paul can, but I think if we could carry on taking it through qual.
Yeah. So and yes, so I mean, just on the learning, you know, it's the very, very familiar communications, pain relief, and extended stays in ED. Yeah, in terms of the experience that people are having, but yeah.
I'm conscious of time, but there will be new guidance coming out around end of life care in the spring.
Okay.
And I think we've just been talking about health equity, and I think this is a huge issue in that area. So I think going forward, this is an area we might need to wish to spend more time on as a system.
Okay, and also cultural competence at the time of death and that kind of stuff. Yeah, very good point. Okay, but for today, I think we are being asked to approve the 2 documents in the pack, and note that there are no particular areas of concern other than the areas of learning that have been identified. Okay, thank you. Treasury management policy, Neil.
Yeah, so only minor changes reflecting change in job titles, change in committees. It's already been approved by the Finance and Estates Committee. We would expect to bring this back to the board in the course of next year on the basis of merger to reflect arrangements across the new organisation.
Okay, any thoughts, comments? It's minor amendments or alterations, I should say. Okay, so happy to approve that. Yes, okay. In which case we'll go on to the integrated governance report and the upward report from committees. Beginning, Roy, with digital, anything that you would want to bring to the board's attention?
I'll take the report as read. Nothing in particular other than we are very much focused on the actions required ahead of the merger. Forming single digital enterprise teams, moving to a single tenant, and a number of sort of must-have items that we need for day one before the merger happens, knowing that overall, there will be a knock-on effect. Well, there will be an implication on the digital team and the staff post merger. By and large, things are on track and on plan, other than some limited assurances that we received around the audit that was done. But that's the summary of it.
Thank you. Anything to add, Neil, from your perspective?
I suppose I feel compelled to describe the limited assurances are around our business continuity and cyber security resilience. So I think we've described the challenges we've got. In fact, we have a large enterprise network case, hopefully winging its way round for its final approvals that will enable us to remedy much of this. So it's dealing with the issues that are known. It's helpful having the independent scrutiny to keep us aware of them.
So it does talk about the fact that full business case was not endorsed. Is there a timeline, Neil, on when you expect to be able to bring that back?
I'm hoping that we might be able to have a conversation this afternoon around its journey for approval.
Okay. All right, thank you. Any comments from other colleagues around the table? Anything to pick up? No? Okay, let's move on then to finance and estates. So, Martin?
Mainly finance this month, I think, and we've had the update from Neil, so happy to take any questions.
Okay. Anything, Neil, you would want to add from the committee? Shouldn't think that.
No, thank you.
No, okay. Any points anybody wants to pursue from the committee upward report? Okay. People, Linda.
Yeah, so mindful of time, I'll take the report as read, Chair. Just a couple of things to pull out, I think. Some good news around the fact that we're now aligning all of our workforce metrics with the national measures, which means we'll be able to benchmark in a broader sense. And also we're looking at the draft People National Target Operating Model, which is going to mean people services being delivered from a hub with certain things remaining local, like your business partner support. But that should allow us to drive efficiencies, give an improved service, and hopefully a faster service. And so that will work. We'll work closely with all the relevant people to make that happen. So there's a lot, I think, around the strategic piece around aligning and sharing best practice and doing things together. The other thing I'd probably pull out is the V&A work. We received a joint assurance report on violence and aggression. That was of particular concern at NBT. We'd seen an upspike in racism actions against staff. Not good. So both trusts already had well-developed programmes in place, but again now we're coming together, starting to achieve some quick wins, more work to be done there, and it was very clear that we don't think that any level of violence or aggression is acceptable, and we absolutely need to eradicate that. But I think there are some good early quick wins. We covered benefits realisation, so I won't talk about that. Yes, Jenny's been doing some good work with the team to just pull together an interim strategy, if you like, rather than a fully blown group people strategy. And what she's come up with are 6 key pillars against which we're now going to report against going forwards, hold ourselves to account to going forwards. That will buy us some time to then think about what the overall strategy needs to look like for the longer term merged entity, which will be quite different from what we need in the here and now. And to end on a high note, NBT won Best UK Employer of the Year at the Nursing Staff Times Awards. So just a little bit of celebration and thanks to the team for that. And maybe just a nice thing to close on.
Yeah, and well done to all concerned. That's excellent news. Anything that people would want to pick up from that upward report? No? Okay, in which case... Quality and Outcomes Committee, Sarah. Anything to highlight from your perspective?
No, you have the report. I think I just wanted to highlight the fact that the committee was very concerned about the no criteria to reside position, and therefore I'm glad we will discuss that later.
Okay, thank you very much. Anything else that people would want to pick up? No. Okay. Register of seals. I'm going to look to you, Xavier, because I guess you know what's what with this.
Purely for information, Chair. So if there's any specific questions, happy to probably take them offline, given that they probably relate to commercial in confidence signatures. Most of them relate to land registry, renting rooms. So.
Okay. Thank you. So for information. Any other business? I'd just like to acknowledge Mark, because this is Mark's last meeting. Mark, thank you. I'm not sure how long you have been with UHDW.
Well, just over 3 years for this
Yeah.
this stint anyway.
Yeah. Well, you had a previous life.
Yeah, exactly, yes.
Yeah. But we're going to miss you. Thank you so much for everything you've done, and on to pastures new in at the end of January, I believe. So thank you very much indeed, Mark. We'd just like to acknowledge the contribution that you've made to the board and keeping us all afloat during, well, let's say an interesting year in governance terms. So so thank you. You've been a huge help and support. Thank you very much.
Thank you, Ingrid. Thank you. Thank you all.